Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. Today we're exploring the topic of translational orthopaedic research in practice. This podcast is sponsored by Macquarie University Hospital, part of MQ Health, a trailblazer in healthcare, education and research. Joining me is Associate Professor Sumit Raniga, who is an award-winning subspecialist, internationally recognised orthopaedic shoulder and elbow surgeon. He's the director of the Translational Orthopaedic Research Lab and head of upper limb surgery and therapy at Macquarie University Hospital. Dr. Michael Dan is a lower limb orthopaedic specialist with further formal subspeciality training from the Lyon Knee School in France. Associate Professor Raniga, can you briefly describe what translational orthopaedic research is and how it impacts patient care?
That's a great question, Sally, and it's a question I get asked often. What is translational research, and specifically, what is translational orthopedic research? In terms of my understanding and how I explain it, it's essentially basic sciences research, which is really focused on understanding the nature of a condition, the treatment of a condition, or the prevention of a condition at the most basic scientific level, which can then be taken to the patients to improve their outcomes pretty much straight away. So if you think about translational orthopedic research, in our case, a lot of it's biomechanics. The musculoskeletal system, which we use all our joints for walk, mobility, reaching things, is all based on biomechanics. And when we're actually treating our patients, what are we trying to do? We're trying to improve the biomechanics so they can do things better or improve their lives by having less pain or more function. And it's all based on improving the biomechanics of their situation. And so in our case, the translational research is really focused on understanding the biomechanics of a joint, understanding how disease affects it, and then understanding how treatments are going to improve the biomechanics. So then therefore the patient's going to get pain relief or improved function. And that's an example. And so in that regard, translational orthopedic research is essentially knowing where the gaps lie in terms of our knowledge, understanding, or application of treatments for patients, and then designing experiments that are basic scientific studies to answer that question so that then we can make a direct impact, as opposed to a lot of labs around the world that do the science for the purpose of science almost, but they don't really have an application until later, where then they have to figure out how they're going to apply it. In this form of science, we know what the gap is, and we design experiments to answer that question so we can make a direct and fast impact.
Tell us about the research you were doing at the Macquarie Translational Orthopaedic Research Lab.
Sure. So in 2019, when I finished my fellowships in shoulder and elbow surgery, and throughout my orthopedic training, one of the things that really, disturbed me was that a lot of the things we do in orthopedics, for example, joint replacement surgery, we have all these amazing innovations that come into the market. A lot of them are designed in silico with finite element analysis or simple scientific concepts, or predominantly computer simulations where the designs occur. And then very basic types of tests are done, and then they go into patients. And that concerned me because throughout the orthopedic history, we've seen implants fail. We've seen patients suffer because of this sort of very traditional way of bringing things into the market. And I used to always think there has to be a middle step. There has to be a way where we can work out these problems earlier so that our patients don't suffer. So for example, a few years ago, there was an elbow replacement that was brought into the market. The Mayo Clinic, which is one of the world's meccas in this field of orthopedics, implanted these, and they had failure rates that were close to 50%. But if you really studied those failures, they should have never happened if there was an environment where you could test it. So when I came back, one of the thoughts I had is that wouldn't it be amazing to basically be able to test these concepts and ideas and these designs before putting it into patients? So I have a real interest in the shoulder. It's a fascinating joint. It's like a surfboard with a golf tee and a golf ball on it. has this remarkable symphony of movement which is highly unconstrained. Unlike any other joint in the human body, where the hip is very constrained by bones, the shoulder has no constraint. That's why it gives you this beautiful symphony of movement, I call it. And I thought to myself, wouldn't it be amazing to be able to take a cadaveric shoulder, where whether it's a donated body or it's a body that you can acquire from companies that have body for scientific experiments, be able to move that shoulder just like your shoulder, study the biomechanics live right in front of you, with the ability to move it with robotics and mechatronics, which we are doing now, so they can understand the biomechanics of that shoulder. Then you can create an insult just like a patient, so a lesion or a pathology, study the biomechanics of that, and then design new surgical techniques or test the surgical techniques that have been done for years to really see how it works, or implant a prosthesis in there and be able to tell the company within 2 weeks, this works, this doesn't, change this, change that, so that by whatever invention you've got, whether it be surgical techniques or prosthesis, when it goes into patients, it's gone through this rigorous process of scientific testing and experimentation at the most basic biomechanics level so that our patients do well with it. So it's about getting time zero biomechanics as good as it can be so that it can stand the test of follow-up. Not the conventional way where we implant it and then we study all of them over a year. Some of them do well and then some of them fail, and we think, oh, what did we do wrong? How do we fix that? It's the other approach, and that's where translational research is really powerful, because you do the basic sciences first, have a strong scientific basis for what you're doing before you go into patients. And that's what we do in our lab. And the jewel of our lab is a in vitro cadaveric shoulder simulator, which can take a dead person's shoulder and move it just like yours with the same degree of complexity and smoothness. And we can do all these amazing experiments to understand how it works and how we can improve lives. We have a hand, we're building a knee, we're about to build a spinopelvic one, and we're just in discussions about grant funding for that.
Can you share insights into the innovative research you're leading on frozen shoulder at Macquarie University Hospital?
It's really interesting you're speaking to me today, because today we have just started a clinical trial to treat frozen shoulder. Frozen shoulder has no treatments. Nothing changes the natural history or the severity. And in 2016, I had an idea about how to treat frozen shoulder with a molecular therapy. And today, we actually treated the first person with a molecular therapy for frozen shoulder ever in this very hospital. And I'm so excited, but also nervous, because I'm really hoping it's going to make a difference to these patients without compromising safety. So we do everything from molecular therapies to biomechanics, which is our major focus.
You mentioned you use cadaveric tissue. How does your research incorporate cadaveric studies?
So, cadaveric tissue is an amazing resource. So these people who donate their bodies to science, and as you know, the conventional way of using that is that medical schools teach anatomy to patients, right? To students. But those bodies are also a remarkable resource to understand pathology if you are that way inclined. So in my mind, I thought, wouldn't it be amazing to take cadaveric tissue, which is a dead person's donated body, you then isolate all the muscles, and in our case, in our simulator, there's 8 muscles. I can take you through them. It's the upper and lower subscapularis, which is part of the rotator cuff, supraspinatus, part of the rotator cuff, infraspinatus teres minor, part of the rotator cuff of the shoulder, and the 3 heads of deltoid. And we use robotics, mechatronic engineering, to actually move the tendons and muscles just like you move the tendons and muscles in your body, in your shoulder, when your mind commands it. And we've developed a computer algorithm that works just like your brain in terms of commanding those muscular tendinous units. So therefore, we can command the shoulder to move in space just like when you go to pick up a cup of coffee, our simulator can do the same thing for the shoulder. And it moves with the same degree of complexity. Furthermore, you can create injuries. So we can turn on and off any part of the rotator cuff or the deltoid, and it actually manifests exactly how patients come to me in clinics when they have a tear of the rotator cuff. And then you can create novel surgical solutions, or you can do a replacement within it, and you can correct it to how it was. So now you have tangible reliable biomechanical basic sciences data on what happens to a shoulder when there's a pathology because you have an internal control. It was normal until we created the problem, and then you can fix it. So that's what we do in our lab. Right now, there's a experiment that started at 1 a.m. yesterday, Sally. It's nearly 40 hours. They're still going. And they're doing all these different surgical techniques to see how we can make these shoulders better after we create a problem.
That's amazing. So, how does the collaboration between academic surgeons, radiologists, biomechanical engineers, and industry drive innovation in medical research? And what impact does it have on improving patient outcomes?
So, as you remember from the first question, you said to me, what is translational research? I think the difference between normal basic sciences research and this type of research is that when we're identifying a gap in the knowledge or we're asking a question scientifically, it is through collaboration. So it'll be orthopedic surgeons like me who are true subspecialist shoulder and elbow surgeons, for example, or a knee surgeon who says, look, this is a problem we've got. We don't understand this, or we'd like to find a new way of solving this problem, or can you tell us how this works? Then we get together with engineers, the radiologists who provide imaging. We get together with the basic scientists who are biomedical engineers. We get together with anatomists who know how to do dissections. And we all sit together in collaboration. And we say, okay, how do we design an experiment that's going to provide us with this very answer that that we require to improve our patients' lives and outcome? And then we'll methodologically go through designing a protocol, designing an experimental model, and in our case, in our simulator, to answer that question. Sadly, getting funding for orthopedic research is very difficult because it doesn't kill people. As I said to all my patients who come with a shoulder problem, I present them all the options and I say, you don't have to have surgery. Either you modify your lifestyle to accommodate your shoulder, or you modify your shoulder to accommodate your lifestyle. You don't have to have surgery because it's not going to kill you. That's a major disadvantage for us in this field of research because the funding bodies always tend to fund cancer. They will fund neurodegenerative programs, heart disease. Why? Because it has a more devastating impact on mortality, while this is all about elective surgery that improves function in life, but still important because it gives you independence to live the way you want to live.
What do you do to secure research funding from industry?
I try and say to industry, listen, if you're trying to sell this prosthesis, then you must also have the same motivation as I do or everyone else does in the community, is that you must do the absolute best for your patients, because if you do that, the financial returns for industry will obviously grow. But the only way you can get the best out of what you've developed is to do the basic sciences experiments. So in our lab, we work with Swiss companies predominantly, American companies where they have designed a platform or a system of prosthesis, for example, a shoulder replacement. And we will do all the experiments to make sure that not only does it work the way they've designed it, but the implementation, the way the surgeon should be implanting these prostheses, the preoperative planning is appropriately done to get the best use out of that implant, to make it the absolute best that it can be. And so that's where industry comes in, because they provide us the opportunity to do this research and the funding to do this research. So it really is a partnership. And in terms of improving patient outcomes, you can imagine when we provide that data to the company, it directly impacts how they educate their surgeons, how they implant the prosthesis, and finding the sweet spots and making sure surgeons are not doing something out extraordinary from where the implant may not work as well it should. So it's all about education. It's all about understanding. And I always say whenever I lecture and give talks, it doesn't matter what implant you use. The most important thing is you must understand its personality. You must understand its strengths and its weaknesses so you can do the best for your patients. And that's what we do in our lab, is we characterize and understand the personality of these surgical techniques and these prostheses so that its application in the patients is to the absolute best of the surgeon's ability.
Fascinating. What are the ethical considerations when translating orthopedic research into practice, particularly with novel treatments or technologies?
This is the best thing about translational research. The reason I say that is if you look at the surgical sciences overall, if you can see it all through the literature, someone has a pathology or a problem, a surgeon who thinks of an idea says, oh, look, this may work. And then they try it and they develop what I'd term a rock collection of trying this in a few patients. And then they follow them up with time. And then they come and tell the world audience that, look, at 6-month follow-up, it's working. The patients are doing better. And then at 1 year, it's pretty good. And there's been lots of new waves of discoveries and surgical ideas that have come through. And then 5 years later, you never hear about it again. No one talks about it. And you think, oh, what happened there? They were so feverishly supportive and they went all around the world talking about this new surgical technique. And now no one's talking about it. And then you start seeing literature that says, oh, it's not working as well. Now, that's an ethical dilemma. Why did that even happen, right? Well, what we do is we say, okay, let's really understand this novel surgical idea you've got at the most basic sciences level with strong data, good scientific experimentation that's independent. And then you say, okay, it works at time zero. The biomechanics make sense. I think we're safe to start doing this in patients. So I actually think in terms of developing novel treatments and technologies with translational research is actually probably more ethical because you actually have good data to then try it in patients. In fact, a couple of years ago, the EFORT, which is the European Group of Orthopaedic Society, I think it's called EFORT, EFFORT, European Society of Orthopedic Trauma and Surgery, I think. I can't remember the terminology. They actually passed a consensus, which was well over 90% from their members, that nearly everything should have basic sciences data, but not everything does. And so in that regard, I actually feel very privileged that I'm in an environment where everything we think of that's novel, we do the basic sciences before we go to patients. So the ethical considerations are always in mind. In fact, that is the altruistic motivation for basic sciences research, is that we should not be doing this without having basic sciences data. So I actually feel very lucky to be able to do this in our lab. So for example, if I think of an idea, or if one of my colleagues around in Switzerland, right, there's a lot of surgeons who are worldwide leaders now coming and working with us in our lab here in Sydney, developing surgical techniques which they've thought of, and they're doing all the testing to make sure it's safe biomechanically in our shoulder simulator, for example. So I actually think that the ethical considerations are almost the whole motivation for why we do what we do.
And how do you see the field of orthopedic research evolving over the next decade?
So at the moment, one of the real focuses, and this is a real focus of industry too, because industry is a big player in orthopedics. They drive a lot of the innovation, but they also drive a lot of trends which may not have good evidence. So, and this is where our collaboration with industry is very important, because I keep emphasizing to them that time zero biomechanics is the key. If you get time zero right, you will stand the test of follow-up. And a lot of the good industry partners realize that, and they come and work with us in that area to get the basic sciences. At the moment in orthopedics, there's a real drive to use enabling technologies. So this is robotics, the use of patient-specific instrumentation, the use of navigation. All of these things help you do your surgery better. It's enabling technologies. AI is having a role in that too for preoperative planning and how we do things better. I think that's great. But the problem is that we've got nearly 30 years of innovation, and not all of it has been truly, madly, deeply tested at the basic sciences level. So there's no point being really precise on a bullseye board, but being off target. So what I mean by that is that first, we must also focus on being accurate. So we must learn what is the bullseye, what is the target. No point having all these enabling technologies that give you precision if you're off target. So that's where it's our duty as basic scientists to provide accurate data so that you can use the enabling technologies then to hit the target. And this is where I see the great hope, but also a concern, because industry keeps driving all these enabling technologies that make you precise, but you still need the basic sciences data to make sure that you have accuracy along with that precision, if you know what I mean.
Yes, I do. What are the key challenges in translating orthopedic research from the lab to the clinic?
Yes. So I think the key challenges, first of all, is to get funding. I have to be honest. You know, every day, every 2 weeks, we have lab meetings. We have these phenomenal ideas. Last week I had the president of the Korean Shoulder and Elbow Society have a Zoom call with us. Wonderful idea to improve patients' lives and in terms of a solution. So the challenges are funding, then attracting good quality people to actually do this type of research. And then from then on, it's the usual challenges, uh, doing good science, publishing it, and then uh, getting people to adopt it. And I think I'm not too worried about that, because I feel that most people, if you do good science, are more accepting, and you can then take it to the next level. And this molecular therapy for frozen shoulder is an example. It's an idea I had in 2016, and today we're doing the clinical trials. I think it's about being sound, clear, honest, and independent. That's one thing I must mention, that in our lab, we work with nearly every company because we don't have any association with anyone. We don't have any ties with anyone. We're just collaborators doing independent research. And therefore, uh, we are very clear when we go into anything that we're going to publish, whether it be positive or negative, so that we can get the truth out into the community. So I actually don't have too many challenges translating the orthopedic research, because even when we do work with industry, they take the data and it's affecting patient outcomes from several months from then. Why? Because they're already teaching their surgeons what they've learned in my lab. But the challenges are we going to be still here in a couple of years because we won't have enough funding? And are we going to have the right people to join us and continue working with us?
Let's go to Dr. Dan, whose research is dedicated to the knee and its complex biomechanics.
Yeah, so for me, I've joined Sumit's team, and what he's done in the shoulder has been remarkable. What they've been able to create in the laboratory is the most advanced shoulder simulator going. And so I'm a knee surgeon, so very keen to implement what Sumit's done with the shoulder into the knee. So we're at that stage where we're just about to have our robot built, and we're going to start translating it into real life research. And this will allow us to look at the time zero biomechanics of the native knee, and then look at that with how pathology changes that biomechanics, and then how we can optimize that with our surgery or our implants. So it's really just the beginning for me, and I'm riding in Sumit's coattails, so to speak, and just trying to emulate what he's done and recreate that. But we're sort of at the beginning of it all, because the biomechanical research that we can do now will be so much more advanced, and we can sort of replicate the activities of daily living with the lower limb now with the new robot. Questions that we've got that we don't have answers for in the clinical world, we'll be able to go back to the drawing board in the laboratory and try to break some of that down better to understand what's happening with the forces and the movement patterns in both the pathological and the normal state, to try to look at what we can do from a surgical perspective to optimize that.
How do you approach the integration of emerging technologies such as AI and robotics into orthopedic practice? And what do you see for these technologies to transform patient care in the future?
Yeah, I think with AI, we're sort of at the beginning of understanding its true limits, and robotics will allow us as surgeons to be more precise and more accurate. And so in our laboratory, we can investigate those techniques and how they can change how accurate and precise we are as surgeons, and how better to provide more data with regards to what the target is that we're hitting. For example, with knee replacements, we know that 10 to 15% of our patients are unhappy, and we're often left scratching our heads for why that is. And so that's where AI with big data can help us better understand what the patterns are for these unhappy patients. And then hopefully with our robotics, we can then try to redefine our targets of what we're trying to hit surgically from a kinematic and kinetic approach with our implants.
If you could identify one key area where translational orthopedic research could make the biggest immediate impact, what would it be?
I think that's it with our implants, and the next step we're going to look at is there's a big drive now to, without the way we put in our knee replacements, we're looking at, we were traditionally putting them in what's called mechanical alignment to optimize the biomechanics of the implant. There's been a real shift towards kinematic alignment, which means recreating the patient's anatomy. There's a gap though in that the implants that we use, they don't accurately replicate our kinematics. And so I think that's where what we're doing at Macquarie can really help out, because we can better understand how to optimize these implants in the way they're created and the way they're implemented to better recreate a more normal and native knee.
Yeah, I think Michael has answered those beautifully. The direction we're going in now, Sally, is that it's kind of personalized medicine. So really understanding the biomechanics, the kinematics, which essentially means forces, movements, tendons, how they glide, the bone's reaction to movement, stresses, strains, and then being able to design solutions that account for all of that and find a sweet spot, but per patient. So, the way your knee works or your shoulder works is different from how Michael's works or mine works. And can we really understand that difference? And can we then use AI to be able to pick up that difference without doing experiments, so it becomes predictable, and then use enabling technologies which we discussed before, such as robotics, patient-specific instrumentation, where we take a scan of your shoulder or your knee and we develop instruments to actually implement our surgery or replace your shoulder or your knee perfectly and closely, and also navigation, and then be not only precise but accurate to reproduce your anatomy to give you the best possible use of your knee, which is unique to you. And that's where all of these enabling technologies will come into play. And then further on from that, you will get follow-up data, just like Michael said, there's big data where AI is very powerful to make us even better and better. But the first thing is to really know and understand the basic sciences. And that's where the accuracy comes in, and the enabling technology makes you more precise, and AI makes you even better at implementing all of that. And that's where it all comes full circle.
Wow, that's really interesting.
I'm very grateful for the opportunity to be part of the Translational Orthopaedic Research group. As a surgeon, I think we can become a little bit like robots ourselves and just get in the practice of reproducing surgical procedures. And so it gives me a real interest to my practice. When I see patients, I have questions. It gives me, we can go back to the starting block at sort of times zero, so to speak, to try to really work out what's going on and have a better understanding before we start changing our techniques. And we can implement them at that time zero phase in the lab before, and prove that what we're doing works from a biomechanical perspective and is safe before we then start going and doing it on our patients.
Thank you to my special guests, Associate Professor Sumit Raniga and Dr. Michael Dan. This podcast is sponsored by Macquarie University Hospital, part of MQ Health, a trailblazer in healthcare education and research. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thanks so much for listening.